So during this 1 year, I will be introducing a few concepts in geriatrics. So this will be the outline of my presentation. I will be mainly discussing on frailty, multimorbidity, few geriatric syndromes, then about comprehensive geriatric assessment, special considerations in prescribing in elderly, ethical dilemmas that we face. So we know that there's a transition in demographics nowadays. So earlier we had the population pyramid had actually the pyramid shape where the base was wider, comprised of children, and then the top was narrower, comprised of elderly population, but now it's slowly becoming barrel shaped. So the top is becoming wider and the base is getting narrower, the other way around, and it's projected in a few decades time, it could be even an inverted barrel shape. So why is this happening? Because one thing is the birth rates are decreasing, life expectancy is increasing because of the advancement in science and technology, and also the migration trend that we see in younger generation. So we are now getting more and more elderly people, and these elderly people have unique health problems in their physical components such as frailty, multimorbidity, disabilities, then and the psychological component because there's social withdrawal, for instance, after retirement, and then also bereavement from losses from the loss of their spouse or friends causing bereavement, then causing anxiety, depression, and then of course with the migration, there's lack of social support as well. Because in Sri Lanka, by law, children should look after their parents. So geriatric medicine is a specialty of medicine concerned with physical, mental, functional, and social conditions in acute, chronic, rehabilitative, preventive, and end-of-life care in older patients. So you would appreciate that this is multidimensional, addressing multi-domains, and also it's spanning across a wide spectrum as well. So let me start with a case study. A 79-year-old female was admitted to the emergency department with shortness of breath and chest pain. Before the current admission, she was independent in basic activities of daily living, needed assistance with instrumental activities of daily living such as shopping, meal preparation, cooking. Mobility, she used a cot stick, and there were no significant concerns in her memory. Her past medical history included type 2 diabetes, hypertension, dyslipidemia, and osteoarthritis. And her home medications were atorvastatin, metformin, glycoside, sitagliptin, losartan, paracetamol, celecoxib, omeprazole, and amitriptyline. So this is one of the common presentations that we see. And during the index admission, she was treated for non-STEMI with acute heart failure and found to have an ejection fraction of 35%. So it was heart failure with reduced ejection fraction. And she was discharged after 1 week. And the discharge medications included fellavine. So in addition to her home medications, dual antiplatelets, beta blockers, mineralocorticoid receptor antagonist, empagliflozin from furosemide were introduced. So if you look at heart failure with reduced ejection fraction and the non-STEMI, dual antiplatelets are justified. Then for heart failure with reduced ejection fraction from heart failure trials, it was shown that beta blockers, mineralocorticoid receptor antagonists, ACE inhibitors, OARBs, then the SGLT2 inhibitors have shown mortality and mortality benefit as well as morbidity benefit. So following discharge, she spent most of the daytime hours in bed. She reported dizziness upon standing from a chair or bed, and she had reduced oral intake due to loss of appetite, and also she developed urinary incontinence. She required assistance with walking, bathing, and dressing. So she was previously independent on her basic activities such as bathing and dressing, but after discharge, now she needed assistance on these activities as well. And she lost interest in her leisure activities and became withdrawn from her family. And after 4 weeks of discharge, she presented to the emergency department following a fall and found to have right-sided fractured neck of femur. So I'll come back to this case. So with regard to the unique problems, it's basically frailty, disability, and multimorbidity. So what does this frailty mean? So it's actually, now when we age, the reserves in our body systems gradually lose. So it's a state of decreased physiological reserves and increased vulnerability to adverse health outcomes. So what happens is, now when we age, there are cellular senescence and other genetic mechanisms that are involved. So the genetic, epigenetic, and environmental factors causing these cumulative molecular and cellular damage. And in addition to that, hormonal changes such as reduction of growth hormone, then the IGF-1, and then increased levels of cortisols, and then the inflammatory response, including interleukin-6, TNF-alpha, the inflammatory cytokines. So they all cause this reduction of physiological reserves in multiple body systems. And it's also contributed by the physical inactivity and other nutritional factors as well. So it's causing frailty. And then what happens is, now when there's reduced physiological reserves in the body, then the body will not have the capacity to face new challenges or new stressors in the environment or in the body. So this is like, if we have good assets, if we have a very good amount in our bank savings, then we don't have to worry about new taxes or whether it's World War III or so, because we can face, because we have enough and more reserves with us. But if we do not have enough savings, then we have to worry when there's a new challenge in the environment or with us. So it's like that. So if there's, so young patients, they have very good reserves in their body. So even if they face with a new stress, then they will bounce back quickly and they will come back to their baseline. But in elderly, because of frailty, they have low body reserves in their body. So even if they face with a minor stress, so this minor stress could be simple cystitis, or it could be even an introduction of a new medication. For instance, if we start an antibiotic without a correct indication, if we start an antibiotic for asymptomatic bacteriuria, then sometimes it can cause more harm by causing anorexia, nausea, vomiting, diarrhea because of those side effects. So this stress could be something like new drug or even simple infection. So what happens is, then they will, during the acute stress, they will anyway reduce their functional capacity, but because of this lack of resilience, inability to withstand this new stress, the recovery would be incomplete. So it's unlikely that they will come back to their pre-morbid baseline, and also the recovery would be harder and longer. So each time, so if this is a robust individual, the recovery would be complete, but when they become frailer, recovery would be incomplete, and ultimately they will come to a point where they will become dependent and they will have disability. So this is the trajectory in end-of-life situations. So if it's a cancer in a young patient, they have very good reserve, so they will be functional until the last stage of their life, and suddenly they can collapse. In organ failure such as heart failures, UPDs, CKD, then they can admit with exacerbation. So each time there would be reduction of their functional capacity leading to death, and this green line indicates the physical and cognitive frailty. So what happens is, when there's an acute illness, there would be reduction of their functional capacity. Their functional reserves are low, so they won't be able to come back to their baseline. And in between also there would be a plateau or a gradual decline, and ultimately with each insult, they will not bounce back to their baseline unless we intervene, and they can die. However, the frailty is dynamic, it's reversible. So there are different models to describe frailty. This is the phenotypic model described by Fried et al. This is mainly focusing on physical factors such as unintentional weight loss, self-reported exhaustion, weakness, slowness, and low physical activity. So if there are 3 or more are present, then considered as frail. But this is only comprised of physical components. Then Rockwood et al. Described cumulative deficit model, that is accumulation. This is accumulation of different deficits causing frailty. So it's more multidimensional, looking at mobility, cognition, mood, social aspects, nutrition, energy. So if you imagine a wall with bricks, and if you remove one brick at a time, so you could imagine if the wall is full with bricks, then it has good strength. But if you remove one brick at a time, then ultimately the deficits will accumulate, and then that wall will lose its strength, and at one point it can collapse. So there are different scales to identify frailty. So clinical frailty scale is widely accepted and widely used. This is also described by Rockwood et al. In the Dalhousie University in Canada. So you can appreciate to which level you would belong. So very fit would be like an athlete who will be doing regular exercises. I think I fit to frailty category 3, managing well but not doing regular exercises. Then vulnerable people, they are independent on their activities and high order instrumental activities of daily living, but they have slowness, so they are vulnerable. And then in mild frailty, they have problems with their higher order instrumental activities of daily living like transportation, cooking, heavy household work. And in moderate frailty, they would have problems with certain basic activities such as bathing as well. And severe frailty, they will be dependent on their personal care. And then 8 would be severe, very severely frail, and terminally ill is 9. So this is basically focused on the functional activity and how much they are dependent. So if a patient is having disability from their young age, for instance, like after spinal cord injury, then this would not be applicable because all disabled patients are not frail. And then the Edmonton Frailty Scale is used in the peri-op setting, especially to prepare patients for elective surgeries. So again, we are looking at the cognition, general health status, functional independence, social support, polypharmacy, nutrition, mood, continence, and functional performance. Then there are other scales such as Prisma 7 questionnaire, then timed up and go test. So the multimorbidity, as we all know, it's the presence of 2 or more chronic illnesses occurring at a person at the same time. So when they become older, there will be accumulation of these multiple chronic illnesses such as diabetes, hypertension, ischemic heart disease, Parkinson's. So there are 5 geriatric giants. I would like to introduce them. So one is immobility. So that is the sudden loss of mobility. So this could happen following a stroke or with knee joint osteoarthritis, sometimes because of fear of falling, or sarcopenia, proximal myopathy, and also because of deconditioning. So what happens is after some time, like a week of hospitalization, being in the bed, then when we are trying to discharge the patient, they will be very deconditioned. So they will have postural dizziness, and then they would have reduced muscle weakness. They will have muscle weakness causing immobility. Then the other thing is the instability and falls. So one of the mistakes we do as medical staff is we name them as accidental falls or mechanical falls. So remember, in elderly, there are no accidental falls or mechanical falls. It's wrong terminology. I mean, as medical students also, we are using this in BHTs, but it's wrong because if we analyze the root cause, there's always a reason behind these falls. So there could be intrinsic factors such as, so it's important to take the history to identify whether the patient had any sinister medical features such as preceding any chest pain, palpitations, dizziness, syncope, those features. But then at the same time, we should analyze and see whether there are any other risk factors that are prevailing, such as the vision, then the cardiovascular examination to look at for any irregular pulse, then the murmurs, postural hypotension is very important, then the neurologic examination, proximal myopathy, cerebellar signs for coordination, Parkinsonism, then knee joint musculoskeletal like knee joint osteoarthritis, peripheral neuropathy. So those are common intrinsic factors. Then it's very important to look at the drug chart because most of the time the medications are contributing, such as antihypertensives, anticholinergics, benzodiazepines. Then the extrinsic or the environmental risk factors such as steps, then the toilets, sometimes they have Scottian type of toilets, so they cannot, when they have proximal myopathy or knee joint osteoarthritis, they cannot get up. Then sometimes even pets and dogs, and sometimes the clothes that they wear also could be contributing to falls. And then with the falls, they can develop many injuries, head injury, then fractures and other fragility fractures, and also rib fractures. Then incontinence is the other geriatric giant, which is commonly overlooked by us. Incontinence could be either urinary incontinence or fecal incontinence. So urinary incontinence could be type of urge incontinence, that is the when they get the urge, they cannot hold until they reach the toilet, they will leak. Stress incontinence is when they cough or sneeze, when the intra-abdominal pressure rises, leaking of urine. Then the overflow incontinence, that is when there's a block to the outflow tract, distended bladder causing overflow incontinence. And then functional incontinence, that is because of the mobility impairment. Again, they won't be able to reach the toilet on time and then they can leak. So urinary incontinence is we are overlooking, and they are also having embarrassment to express this with us, but it could be the major hampering factor for their social participation. Then the other fact is the fecal incontinence. One of the common things that we see, especially in immobile patients, is that they develop constipation and then they develop overflow diarrhea, which will be manifesting as fecal incontinence. So doing a parental examination to see whether they are having loaded rectum, to look at the anal tone and the perianal sensation, because this also could be secondary to a neurological problem like spinal cord disease, spinal cord metastasis, so coda equina causing black senile tone is also could be a contributory factor. Then the other one is the intellectual impairment. So the gradually progressive cognitive decline in one or more domains is dementia. So that should be significant from their baseline. So sometimes in our cohort of patients, if we ask the routine 480 and other AMTAs and other things, we would think that they're having cognitive impairment, but sometimes our patients are they have not attended their schools, and they are not mainly like looking at news or anything, so they are not really know what is happening, but that is their baseline. So in that case, we do not consider it as dementia. There should be a significant change from their baseline, and that should be significant enough to interfere with the higher order instrumental activities of daily living. So that is the dementia. So those cognitive domains could be learning and memory, the executive functions, complex attention, executive functions, then the language, the social cognition, and the motor skills. In contrast to dementia, we see delirium often in our medical wards. So that is the acute fluctuating syndrome of altered attention, awareness, and cognition. So it's acute onset. So the dementia is gradually progressive. In contrast, delirium is acute onset and it's fluctuating. So nurses will tell that in the night, this patient became aggressive, trying to remove IV cannulas, IV lines and everything. But in the morning, when you do ward rounds, they will be very calm. That is because it's the fluctuating in nature. And the main deficit would be in the attention, but at the same time, there would be problems in other cognitive domains as well. So often there are predisposing factors such as sarcopenia, frailty, polypharmacy, vision and sensory hearing impairment, dementia. But it's very important to identify the precipitating factors. So sometimes it could be simply the change in the environment, because a dementia patient will be more they will be more familiar with their environment, and once they come to the hospital, then that change in the environment with the new people, new noises and everything, they will become confused. Then simple infections such as urinary tract infections, then the lines that we put, the cannulas, catheters, could be a cause. Then the pain itself. So delirious patients would not be able to express pain, but we should use non-verbal cues such as body language, facial expressions to identify pain and address pain. Sometimes simply giving paracetamol regularly would control delirium. Then the other thing is constipation. Sometimes in wards, no one in the ward does not know when the patient last opened their bowels. So it's important to maintain a bowel chart as well to look at constipation. Then other electrolyte disturbances, and of course the medications. Then it comes to delirium. It could be hypoactive, hyperactive, and mixed. So the hyperactive delirium is the one that we commonly see. We identify because the patient will become aggressive, try to remove everything. That is the hyperactive delirium. Hypoactive delirium often we miss, we would not diagnose, and it has high mortality as well. So in hypoactive delirium, it would be the opposite. We may even think this could be depression, but the key feature is it's an acute onset and that's fluctuating in nature, but otherwise the patient will be withdrawn from the society or from the family. They would be apathetic, just staring, and then the words that they speak will be very few words. So that is the hypoactive delirium and the mixed. So hypoactive delirium could be easily missed, but it has high mortality. So when we are managing delirium, non-pharmacological measures is the first thing. So the important thing is identification of the causes or the precipitating factors of delirium, then non-pharmacological measures. So the pain management, relieving constipation, drug chart are very important, and also orientation, the familiar things, then clock and calendar. So likewise, the orientation strategies are important. Pharmacological measures should be used only when those non-pharmacological measures have failed and the patient poses a risk of harm to themselves or others. Because for the pharmacological measures, those are not proven to be correct in the delirium. It's just the symptom control. It cannot reverse delirium. So we have to identify the reason for delirium and then correct it, but they cannot. It's only for the symptoms. So if the patient becomes very aggressive, then only we should give. And that also not on a regular basis. So remember, if the patient is having, now what we usually use is antipsychotic like haloperidol, and the dose commonly used in wards is 5 milligram. That is wrong. 5 milligram is very, very, very high for elderly, and then by giving 5 milligram dose of haloperidol, the patient will be knocked out. So it should be 0.5 milligram, and you can repeat after half an hour depending on the patient's response. So IM haloperidol 0.5 milligram. And remember, if the patient is having Parkinson's, you cannot give haloperidol. So in that case, we may have to use something like benzodiazepine. But this should be given only if it is necessary, not on a regular basis. And the other problem with haloperidol is it can cause QT interval prolongation. So if there are medications that can cause QT interval prolongation, we have to monitor the QT interval as well. So the dose is IM haloperidol 0.5 milligram on PRN basis, and that is also should be used when non-pharmacological measures fail. And then the other common problem is iatrogenic illness, what we do to the patients. And elderly patients are more susceptible to develop problems with what we do. So one thing is polypharmacy. So the polypharmacy is the concurrent use of 5 or more medications, which should include prescribed, over-the-counter, herbal, and complementary medications. And with multimorbidity, sometimes this is inevitable, but giving appropriate or rational medications is the most important thing. In addition to that, the nosocomial infections, catheterization also can cause problems. So when we are putting a catheter, there should be a clear indication. It should not be put for the convenience sake of the carer or the nursing staff. So if there's like, if you need accurate fluid balance chart, yes, we may. But otherwise, or else sometimes for the grade 3-4 pressure ulcers to maintain the skin integrity, yes, we can justify putting a catheter. But sometimes when a patient is admitted to the ward and when they become immobile, the carer, who will be a paid bystander sometimes, they will tell to put a catheter. And we should not do that because that can introduce infection. And even after about week of catheterization, the bladder will become desensitized and it can cause incontinence. So if we go back to our patient, so who presented with non-STEMI and heart failure. So if you look at the patient's clinical frailty scale, so initially before the admission, she was belonging to mild frail category because she needed assistance for higher order instrumental activities of daily living. Then she was diagnosed with non-STEMI and acute heart failure, discharged with polypharmacy. So you would appreciate that even though these are guideline specific or guideline proven and trial proven medications, that has caused harm to the patient because we have started all the medications at once without comparing the risk and benefit. And then patient probably had developed hypoactive delirium. So that's why she has now withdrawn from her family. So that is an element of hypoactive delirium and all other problems that we discussed earlier, the immobility, the incontinence, then the iatrogenic problems, and then ultimately a fall and a fracture. So how can we modify the frailty? It's by the comprehensive geriatric assessment. So it's a holistic and multidimensional patient-centered approach, and it's delivered by a multidisciplinary team. So there we address all the domains of a patient, including physical, socioeconomic and environmental factors, functional, mobility and balance, psychological, and medication review. This would take like hours sometimes. And after assessment, we create a problem list, then develop a personalized care plan, intervene, and then regularly assess the patient. So this MDT is comprised of the geriatrician, the physiotherapist, occupational therapist, nurse, nutrition physician, then the psychologist or the psychiatrist, and the caregiver and the family. So what are the important factors when you're prescribing in elderly? So there are pharmacokinetic and pharmacodynamic changes that are occurring in elderly. So pharmacokinetic changes are what does the body do, what the body does to the drug. So that is the ADME, absorption, distribution, metabolism, and elimination. So with aging, there are physiological changes occurring in the body, reducing absorption, increasing fat composition in the body. So therefore, increasing the T-half of fat-soluble vitamins, then reduction of metabolism in liver, and also elimination. So these are the pharmacokinetic changes. And there are pharmacodynamic changes that are also occurring. For instance, there would be alteration or the reduction of number and the sensitivity of receptors. For instance, with the neurodegeneration, dopamine receptors in the brain will be reduced. Therefore, even if you give an antipsychotic, they have very high susceptibility to develop Parkinson features. And that's limited evidence based. So even though there are clinical trials, often elderly frail patients are excluded from these clinical trials. And if you look at guidelines, they are developed mostly for one disease. But when the patient is frail and morbid with multiple diseases, then it is a challenge to manage such patient. And on top of that, they have other cognitive problems as well. So it's not straightforward. We cannot go by a book. And then, of course, we have to consider medication formulations, because if they have visual impairment, giving insulin would not be practical. If they have problems with their manual dexterity, then the inhaler would be problematic. So we have to consider all those factors when we are prescribing in elderly. So we should start low and go slow and assess frailty, cognition, renal and liver functions. For instance, if they have cognitive problems, sometimes actually the dementia would be it would be very subtle, because I mentioned that it's a change from the baseline. So if the patient is already a high functioning person, like a doctor, a professor, an engineer, they would have very high cognitive reserves. So there would be very subtle changes. So sometimes when the patient is having poor disease control, like for instance poor glycemic control, and when we probe into the adherence, then we may detect that the patient is having cognitive deficits. So we have to assess the cognition, because if the patient is having dementia, we have to see whether the patient is having a caregiver to give those medications. Otherwise, it will be problematic with regard to adherence. Then consider non-pharmacological methods whenever possible, like for constipation or knee joint pain, and avoid high-risk medications, including medications with high anticholinergic burden, benzodiazepines and opioids. So these are the medications with high anticholinergic burden. So amitriptyline, as well as medications that we use for urge incontinence, such as oxybutynin, solifenacine, tolterodine, having very high anticholinergic burden. Even medications such as cetirizine, sertraline has anticholinergic, like a moderate anticholinergic burden. And then prednisolone, codeine, tramadol, they also have an anticholinergic burden of 1. So there are anticholinergic burden calculators. We can put any of the medications and see whether they're having any anticholinergic properties. So try to avoid these medications and use simplified regimes and use suitable formulations, and review regularly for necessity, indication, adverse drug reactions and adherence. Then consider deprescribing. So for instance, now for primary prevention, antiplatelets are not indicated. And even in elderly frail, starting statin for primary prevention is not justifiable. And then we should not go for tight blood pressure, tight glycemic control in frail elderly. And it's very important to have a shared decision making with the patient and the family. And for deprescribing, there are tools such as start-stop criteria, BS criteria that could be helpful. So let me move to the case study 2. It's about a 90-year-old male with a background history of moderate dementia with behavioral and psychological symptoms of dementia. So he was evaluated at the medical clinic with a clinical frailty scale of 6, and routine blood tests revealed evidence of iron deficiency anemia. So how to manage iron deficiency anemia in this patient? So in a 90-year-old patient with dementia and BPSD, so if we, from medical students' time, we know how to evaluate iron deficiency anemia. That is the history, about the diet, then the GI problems, whether there are any bleeding manifestations. And then usually in a young patient, we would consider endoscopy, low G endoscopy, those things as well. But this is a 90-year-old patient with moderate dementia with behavioral and psychological symptoms of dementia as well. So how much are we going to investigate is the problem. Now there's a pandemic of over-treatment and over-investigations. So especially it comes to the elderly. So when we are doing an investigation, we should think whether this would change the management of our patient. If it's not going to change the management, do not do that investigation, because all investigations have their own problems and their burden. For instance, even if you do we may think it's a simple blood test, but these simple blood tests also have false positive and false negative values. And if it gives rise to a false positive result, that could even trigger a cascade of other investigations. Therefore, if it is not going to change the management, and if it's not going to help the patient, we should avoid such investigations. And the other thing is, the chronological age of a patient should not be the deciding factor to treat whether to investigate or not. It should be the frailty. So if the patient is robust or fit, even though 90-year-old, then if we do not offer the treatment, That is wrong. So sometimes even if it's a 90-year-old patient, not frail, we may even consider ICU because that patient is not frail and having good physiological reserves, and there's a high chance that we could reverse the pathology. So in that case, if the patient is robust and fit, we should offer investigations and treatment. At the same time, if the patient is frail and not fit, then doing over investigations or over treatment could be harmful to the patient. So if we think that there's a reasonable chance of overall benefit from the proposed treatment, then of course we should provide the treatment to the patient. That is appropriate commission of care. At the same time, if there's a reasonable chance and if we do not provide the treatment or investigation, that would be potential ageism. So that means we are not doing the correct thing to the patient. At the same time, if there's little chance of overall benefit from the proposed treatment, then of course we should not provide the treatment. That is omission of care. For instance, in that dementia patient, if we try to do an endoscope to see whether the patient is having peptic ulcer disease or low G endoscopy, that would be very, very challenging, would be very problematic. Because the patient is behavioral and psychological symptoms of dementia means the patient would not be compliant, and putting a scope would cause delirium and it can cause more harm to the patient. Patient will struggle. So that would cause more problems. And at the same time, in a 90-year-old frail elderly, even if we diagnose a malignancy, what are we going to offer? That patient would not be fit enough to undergo major surgery, neither chemotherapy. So in that context, if we provide invasive procedures, then that would be harmful to the patient. So if there's little chance of overall benefit from the proposed treatment should be, that should not be provided. It's appropriate omission of care. So in case if there's little chance of overall benefit and if we provide that treatment, it would be over-diagnosis and over-treatment with potential for harm, discomfort, and then also it would be a system waste as well. So then it comes to the main principle where we should explore what actually the patient wants. So that is the autonomy. So we know that there are 4 ethical pillars, that is the autonomy, beneficence, non-maleficence, and justice. So autonomy is the most important overarching principle, that is the patient's right to make a decision. So patient has a right to refuse treatment, however they do not have a right to demand treatment. So we should explore what actually the patient wants, what are the patient's values, goals and preferences before plan any investigation or treatment. So that's why it should be a patient-centered approach, and communication is the key. And we should come to a consensus and make a shared decision before approaching to any investigation or treatment, especially in geriatrics. So then in our patient who is having dementia, we should assess whether the patient is having capacity. So the first principle is we should assume that all patients are having capacity. And then we should try, if we do not think that can happen, then we should try to maximize the capacity making ability by providing communication support, sometimes visual aids, and sometimes they can also make unwise decisions as well. So when we are assessing whether the patient is having capacity, we see whether the patient can understand information that we tell, whether they can retain it for a sufficient time to make a decision, whether they can weigh the risk and benefits of the decision, and whether they can communicate. So if they do not have this decision-making capacity, then as doctors, we should make the best interest decision for them. So what is the best thing to do? And for that, we have to consider patients' pre-expressed wishes, goals, and preferences as well. So that is about the over-investigations and over-treatment. But communication is the key. So this is my personal experience. So recently, one of my cousins told that her mother was taken for a private sector rheumatologist, and she was having a knee joint osteoarthritis flare. And this consultant ordered multiple investigations. So the cousin was telling me, this time this doctor, it requested so many investigations. So this time this would work. So that is the attitude of our people. So they think if a doctor does many investigations, that doctor would be a best doctor, or that doctor is the best one. But it's not the case. We have to always, that's why the communication is important. Otherwise, the patients and their families would not understand the rationale behind our decision. And when we are making a decision about investigations and diagnosis, especially in elderly, we should always consider this frailty. So this is the case 3. An 88-year-old male with severe dementia was admitted to the medical ward with aspiration pneumonia and delirium. The family wants to start NG feeding. What's your approach? So now I would like to introduce the concept of end of life. So we asked this surprise question. Would I be surprised if this patient died in the next 12 months? If I would not be surprised, that means there's a very high chance that this patient would die in the next 12 months. So that means that patient is probably now approaching end of life. So if I think that, then I have to prepare this patient. So that's why advanced care planning is important. So in a patient with severe dementia, if they lose multiple cognitive domains, including language, then when they develop loss of appetite, unintentional weight loss, then problems with their swallowing and aspiration, that would be an indicator that they are approaching end of life. So this patient now having severe dementia, coming with an episode of aspiration pneumonia, it's highly likely that this patient is approaching end of life. So as this is the first episode, of course, actively treating with IV fluids, IV antibiotics is rational. And then about the NG feeding. So when we are putting an NG tube, so as I mentioned earlier, when we are putting a catheter, again, we should carefully think, is this going to benefit to the patient? What is the rationale? So likewise, when we are putting an NG feeding also, when we are putting an NG tube also, always we should think, is this the correct thing or what is the end point of this? Now in this patient with aspiration pneumonia, even though we put an NG tube, that would not prevent aspiration because still the saliva would be aspirated, and even after a bout of feeding, then that the content could be, there would be reflux, and that can also cause aspiration. So it would not prevent aspiration. That is the first thing. Then this patient is having delirium. So do you think that this patient would keep the NG in? No, that this patient will remove the NG, will become more aggressive. And then what we do commonly is we would tie the patient's arms. But that is very inhuman. Then sometimes when the patient is now, before aspiration, when the patient is reducing their appetite, then sometimes the family will come and tell to put an NG or sometimes to peg tube as well. But in dementia, studies have shown that putting an artificial, this NG or a peg would not improve their motility or their nutrition status. So that would not prolong their life. Therefore, NG or a peg tube is not recommended in dementia patients. Having said that, it's not an absolute. Sometimes, if it's mild to moderate dementia patients, could develop community-acquired pneumonia. So it's not aspiration pneumonia, but it's a community-acquired pneumonia like you and us, you and me. So then what happens during that period, if we treat that community-acquired pneumonia, that pathology is reversible. It's not like aspiration pneumonia. So in that case, if there's a problem in nutrition for a short period, you could consider NG. But that is for a short period, and because we know that the pathology is probably reversible and there would be a good outcome. So that's why that is a rationale, but at the same time, there's a risk of delirium. So we should always discuss with the patient if the patient is having cognitive capacity or with the family about the risks and benefits. Then the other thing is in Parkinson's patients, delivering the anti-Parkinson medication is crucial. If the patient is already established on Parkinson medications and if the patient is admitted to the hospital, if they lose their oral route, then of course, if we do not give them, so unfortunately we do not have transdermal patches such as roticotin patch in Sri Lanka, so then delivering this established anti-Parkinson medications is crucial, otherwise they can develop neuroleptic malignant syndrome from withdrawal from these anti-Parkinson medications. So in that situation, NG would be justifiable, that is actually to deliver these medications. So in this situation, we should explain to the patient and family why we are not putting an NG feed, and then when the patient is having upright posture, we should feed, so initially with IV fluids, but then when the patient is being discharged, we should explain about the feeding at risk. That means we are acknowledging there's a risk of aspiration and we can't prevent that, but for the remaining lifespan, because this patient is probably approaching now end of life, that means that the patient is having a short period to live, so that at that point we are acknowledging the risk and feeding. So that's why it comes the quantity versus quality of life. What would the patient want most, whether it is to live longer or whether it is to live better? That's the values and treatments harmony. So sometimes a patient would want to live until they see the birth of their grandchild, or maybe until the son or the daughter comes from abroad. So that is the quantity. So that sometimes then at that point we may have to consider active treatment even for a short period until their unfulfilled needs are met. But sometimes what they most value is the quality. So that's why when the patient is having cognitive capacity, we should start advanced care planning. So advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal is to help ensure that people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. So when the patient is having cognitive capacity, we discuss with the patient what do they really want. So now we think in our culture sometimes it's difficult, but in my clinic, when I get a patient with advanced dementia, I discuss about these things with the family, and then patient with Parkinson plus when they have cognitive capacity, I try to discuss these with the family, with the patient and the family as well, what they really want. So often they tell, when the patient is having cognitive capacity, they tell that I lived very good life up to now, so I do not want to have any more suffering. So then we should also discuss about resuscitation and withholding and withdrawing treatment as appropriate. This is the final case. A 90-year-old female nursing. So this is actually one of the cases that I encountered when I was undergoing overseas training. A 90-year-old female nursing home resident with a clinical failure scale of 7 with a history of ischemic heart disease, hypertension, and Parkinson's disease presented to the emergency department with melena and hematemesis, followed by a fall. On evaluation, airway is threatened. Saturation is 80% on room air with right lower zone crepitations. A pulse rate is 120 beats per minute with blood pressure of 70/50. And she was only responding to pain. Left on examination, there was feature suggestive of left fractured neck of the femur. Hemoglobin is 5 and lactate is 9. So if you could remember, clinical failure 7 is that the patient is severely frail. She is dependent on basic activities of daily living as well. And here the problems are, she is now having evidence of upper GI bleeding, could be secondary to antiplatelets, or maybe anterior dysplasia or something else, we don't know. Then now she is having hemodynamic instability, lactate of 9, and also possibly now having cerebral hypoperfusion as well. So that's why she is responding to pain. And then there's evidence of aspiration pneumonia. So she is now oxygen dependent. And then the third thing is hip fracture. So how are you going to manage this patient? Whether we are going to go for a proactive approach or whether it would be kind of a palliative approach is the problem. Now, we know that as human beings, we all are immortal and we are not gods, we can't do miracles. So in this patient, to start with, this patient is very frail and now having a major stress of upper GI bleeding, hemodynamic instability, aspiration pneumonia, and a fracture. So if we look at overall mortality, would be very high. Even if you try to actively resuscitate, there's a very high chance that this patient would not have good quality of life. And to consider an upper GI endoscopy in this patient who is oxygen dependent, again it's problematic because we can't remove the oxygen mask. To proceed with an upper GI endoscopy, then the saturation would drop. That means this patient would need intubation to proceed with an upper GI endoscopy because the airway and the airway should be secured with oxygenation. So this patient would need intubation to proceed with an upper GI endoscopy. But if we intubate, would we be able to extubate the patient? It's highly likely then we would not be able to extubate the patient. This patient would need ITU admission. But then what about the quality of life, even if this patient recovered from this illness? So that's the problem. So, so this patient does not have mental capacity at this point to make any decision. Therefore, we discussed with the patient's family about what were the patient's previously expressed wishes, goals, and values. And it was told that she has also expressed that she wanted to have a good quality of life for the remaining life and not to have any invasive procedures. And we as the medical team, now she doesn't have capacity. She not have, in the UK, there were no, for her, there was no any legal bills or living wills or advance directives. So as the medical team, we had to make a best interest decision. And that was taken with a multidisciplinary team with an orthopedic surgeons, then the gastroenterology team and the geriatric team. And after considering all these factors, considering the reversibility and all those things, we decided for palliation. So palliation in this, now I initially mentioned about the end of life. That is, if we think that the patient would die within the next 6 months or 12 months, this patient, when we stop everything, that means the patient would be actually dying. That is, this patient would enter the terminal phase of life. The patient will be dying. So identification of dying process is also a clinical diagnosis. And it's not a failure by the medical team. So we have an inertia to stop those active treatment or to withhold treatment. But if that is going to cause harm to the patient, we should stop those things. That is actually withholding treatment. So we discontinued monitoring because there's no point of monitor observations, no monitor blood pressure and stuff if you're not going to do anything. And also IV fluids. So in terminal phase, if we give IV fluids or subcutaneous fluids, that would cause more harm to the patient because it can increase secretions, then more death rattles, and that can cause even more respiratory distress to the patient. So IV fluids, subcutaneous fluids should be discontinued in the dying phase. But it's very important again to communicate everything with the patient's family and to document that. Otherwise, in our setup, on the next day evening or on the next tomorrow, the following day, there would be a social media post that the patient was admitted to the National Hospital Kandy ETU, nothing was done, saline ekakවත් දුන්නේ, not even an IV saline was given, and patient died. So it's very important that we communicate everything with the patient and the family. And sometimes, often, if we communicate properly, they would understand the futility of everything. But if there's any discrepancy, then should take a second opinion. But we should not do harm to the patient. Then the symptom control in palliative, that is, we started morphine for pain, haloperidol for confusion, and midazolam for shortness of breath. Then she passed peacefully in 2 days. So aim was to provide a peaceful and dignified death. And it's not a failure by the medical team. So my take-home messages are, geriatric medicine is complex and challenging, often involving ethical dilemmas. Comprehensive geriatric assessment is a holistic, multidimensional, patient-centered approach delivered by an interdisciplinary team, and it's the cornerstone of geriatric care. Shared decision-making supported by effective communication is a key principle. That would be the key, the communication. Thank you.